Hello everyone. Welcome back to our YouTube channel. We are going to continue where we stopped in the last class about allergic rhinitis. I really appreciate your suggestions and comments in the comment box so that I can really improvise what I'm giving it to you. So I was waiting for responses such that I can make changes. Always free feel to let me know about your all kind of suggestions, doubts, even discussions. A proper discussion is greatly appreciated. So let us continue with what we were talking about. So we were talking about pharmacological treatment of allergic rhinitis. Pharmacological treatment of allergic rhinitis. So pharmacological treatment, as I said in the last class, there are antihistamines, decongestants, corticosteroids, leukotriene receptor antagonist, immunotherapy, and again anticholinergics. All these drugs are there. First of all, let's talk about anything that is taken oral treatment for allergic rhinitis, and then we will talk about intranasal treatment for allergic rhinitis, which is very effective. Coming to first class antihistamines. Antihistamines, as I said, they are of first generation and second generation. First generation drugs can be diphenhydramine, hydroxyzine, then we have chlorpheniramine, then also we have brompheniramine. And in the second generation, we have very popular drugs, cetirizine, desloratadine, and loratadine is also there, fexofenadine, bilastine, then rupatadine. These are some of the most common drugs which is used as oral agents for the treatment of allergic rhinitis. Among these, some of the drugs are prescription only. They are hydroxyzine is there, then rupatadine, bilastine. These are all taken as prescription. Okay, the cetirizine, all these drugs have their own prescription doses, but suppose cetirizine is available up to prescription, non-prescription dose, OTC dose of 10 milligrams, and then we can take from 20 milligrams, there comes as prescription. So it depends upon the class of the drug, the schedule of the drug, whether it is prescription, non-prescription, behind the counter, over the counter. So all these drugs we will be discussing, the classes will be discussing in the coming chapters, coming classes. And I expect your total contribution as comments, suggestions, which video I have to upload. It depends on you because you are the people who is studying. So I want you to let me know what you want me to take as a class. Now, let's focus on the drugs, as these are the drugs which is used for the treatment of oral treatment. Let us study about the first generation antihistamines and second generation antihistamines a little bit more. Okay, so distinguishing between first generation antihistamines and second generation. First generation, usually, which is the first line of drug? Second generation is the first line of drug because they have more potency, less side effects, and a lot of things which we are going to discuss. Basically, first generation antihistamines are immediate acting. They help with the relief of itching. They treat itching, then redness, lacrimation. They are immediate acting and they are basically competitive antagonists for H1 receptors, okay? But they are non-selective. Okay, they are non-selective H1 antagonist. They are competitive selectors. Competitive means the particular drug will be competing with the histamine 1 receptor with histamine to act on the receptor such that the drug will be binding on the receptor and histamine is not getting a chance to bind to the receptor and give you an action. So that is meant by competitive. Okay, and they are some are reverse antagonist as well because they can decrease the affinity of histamine for histamine receptors. That means down regulating histamine related symptoms. Down regulating means reducing the sensitivity and number of receptors. There is up regulation and down regulation. Down regulation means reduction in sensitivity and number of receptors. Up regulation means increasing sensitivity and number of receptors. They are most commonly we are going to study in adrenergic, cholinergic, ANS chapters. They are very important, which you need to understand. So as I said, these drugs help in itching, also redness, lacrimation, also sneezing, rhinorrhea. All these symptoms can be helped. Okay. And the effect is prime when the patient takes the medication prior to exposure to until finishing the exposure. That's when they become very active. There are few properties of first generation antihistamines. They are highly lipophilic. They are highly lipophilic. Lipophilic means, what does that mean here? They are gonna cross the blood-brain barrier. Definitely. And gonna cause CNS side effects. What can be the most common CNS side effects? Sedation can be there and also cognitive impairment. Okay. And the second thing is that they are non-selective. Non-selective means they have affinity. They can affect the cholinergic receptors as well. They are antagonistic drugs, antihistamines. Antihistamines means opposite. They are giving opposite effects. So they are giving anticholinergic side effects. Non-selective means they are giving some anticholinergic side effects as well. Which is the worst? Which can produce what are the anticholinergic side effects? You might know it well when we come to the adrenergic cholinergic chapters, but still I can just name all those actions, which includes tachycardia, constipation, blurred vision, then dry mouth, dry nasal passages, and also decreased urination. Okay, So these are some of the anticholinergic side effects. It is very bad, right? We are getting CNS side effects, anticholinergic side effects. I told you they have an immediate action, very faster onset of action. At the same time, they have a short duration of action as well. So since they have all these properties, all these side effects, can you imagine what kind of situations are these agents contraindicated? Definitely, patients with chronic cerebrovascular diseases, heart diseases, lung diseases, also bladder obstruction problems, and at the same time, prostatic hypertrophy. Because bladder obstruction problems and prostatic hypertrophy, they will be definitely having problems with urination, and this agent is causing decreased urination, so it can be a problem. They can also block the H1 receptors in the histaminic receptors in the stomach and cannot be used in stenosing peptic ulcer. They cannot be used in narrow ankle glaucoma. So it is a contraindication. The patients, this drug should be used in caution in these all conditions. Okay, now let's come to the second generation antihistamines. Second generation antihistamines has a lot of advantages. First of all, I said they are first line agents. Greater H1 affinity. Less lipophilicity. Do not cross blood-brain barrier. No significant anticholinergic effects. From that itself, we can say they have reduced sedation and CNS effects, reduced or no anticholinergic side effects, greater histamine 1 selectivity, which is very good. So standard doses of second generation antihistamines are less sedating, but if you take when compared with the first generation ones, but when it is taken at higher doses, it can be sedating with an exception of fexofenadine. It is 100% non-sedating. Okay, and while taking both first generation and second generation, there can be a side effect of headache. It can be a very common side effect. And one more thing to be uh, remembered, if one antihistamine is not effective, never stop trying antihistamines. You can switch to another agent. If one is ineffective, you can definitely switch to another agent. Okay. Now let's talk about the rest of the drugs. As I said, if you have any questions, please feel free to drop that in the comment box. There is a combination of second generation antihistamines and corticosteroids, which is nasal. Okay. In this case, we will study about the nasal corticosteroids first. Nasal corticosteroids. What is the main mechanism of action of corticosteroids? You might know, decreasing inflammation. That is the first and foremost thing, because the pathophysiology of allergic rhinitis itself is the inflammation of nasal mucosa. Right. When these are first line, they are first line when there is mild persistent symptoms or moderate to severe symptoms. And the patient is having symptoms for, even if it is mild, for a long period of time, it is first line drug. And even sometimes in moderate to severe allergic rhinitis, this drug is a first line. and these helps with the nasal symptoms. They help more with the nasal symptoms, and they can improve some ocular symptoms as well, some nasal corticosteroids, because allergic conjunctivitis is there. In allergic conjunctivitis, have you seen some drops like prednisone, 1% eye drops, ophthalmic drops? They are helping in allergic conjunctivitis. Some very common nasal corticosteroids include mometasone, furoate. Then we have the and what is there? Mometasone, furoate. Sorry, mometasone, furoate, and fluticasone. These are the very common nasal corticosteroids. And then there is also beclomethasone, budesonide, cyclisonide, and fluticasone, propionate. Then importantly, triamcinolone. A lot of nasal agents, and these are very effective on regular use. Regular or long-term use is very helpful. You might see about the onset and duration. You might see an action within few hours of the first dose, but the complete action or the maximum effects are going to take place in few weeks. So long-term use is always good. It can cause it can cause headache, nasal bleeds at times, not every time, stinging or burning sensation. These are some of the ADRs associated with nasal corticosteroids. In long term, very long term, if the nasal corticosteroids are used for years and so, it can cause some sort of development of nasal tissues, growth of nasal tissues in the nasal passage, but it is associated with long-term usage. And now we can talk about the combination products. Okay. Combination of what? Second generation antihistamine plus nasal corticosteroids. So if intranasal steroids alone are not effective, these comes as the second line. Okay, these are the second line after intranasal corticosteroids alone. These are the second line after intranasal corticosteroids. So let us now see what are the common brands available in Canada. One is Dymista and one is Ryaltris. Let us see what is inside it. This has olopatadine. No, not this one. This is azelastine and fluticasone. This has olopatadine and mometasone. Okay, what is azelastine? Azelastine is a second generation antihistamine, and it has some sort of mast cell stabilizing activity. Some sort of mast cell stabilizing activity. One second. At times, this gives me a hard time. Stabilizing activity. This has a very fast relief. Okay, can be used PID, and still it can cause some sort of burning, stinging feeling in the nasal passage, and also some sort of nose bleeding. Now comes to Ryaltris. It has olopatadine and mometasone. Olopatadine is again a second generation antihistamine and a mast cell stabilizer. But azelastine has got some sort of less mast cell stabilizing activity, but olopatadine has more mast cell stabilizing activity. This has some ADR, which includes metallic taste, headache, and as usual, nasal irritation. Okay, so these are some of the um, reactions, some of the adverse effects, and the common agents used for the treatment of allergic rhinitis. All right, now let's clear the screen. The next one we have to talk about is the nasal, intranasal antihistamines. Intranasal antihistamines. As we discussed, as I said, azelastine, olopatadine, in combination is available in Canada, which is always prescription. It has the same side effects as that of others. And some first generation antihistamines are there, which can be used as nasally. They include phenyramine, sorry, topical antihistamines. Phenyramine is there, antisoline is there, levocabastine is there, but they actually histamine receptors, and as they're the first generation. They have some sort of disadvantages. Second generations are always what to say, they are always preferred. Okay, and next one would be oral decongestants, both oral and nasal decongestants. Let's talk about oral and nasal decongestants. Usually, the drugs which are used as oral or nasal decongestants include pseudoephedrine, oxymetazoline, xylometazoline, phenyramine, or phenylephrine. Okay, I can write it down for you. Pseudoephedrine, oxymetazoline, and xylometazoline. Pseudoephedrine, you might have seen some OTC brands before. Pseudofed. This is one of the most commonly available OTC drug. Pseudoephedrine, oxymetazoline, xylometazoline. Oxymetazoline and xylometazoline both are adrenergic drugs. Then we have phenyramine or phenylephrine. So these three are nasal. This can be taken orally. Right. There are pros and cons for these oral decongestants. Oxymetazoline and xylometazoline you might have seen in India like Otrivine. So Otrivine is same as that of the oxymetazoline. What is the mechanism of action of nasal decongestants? You might be thinking when we have to solve decongestion, it is to avoid the congestion. That means it is vasodilation. But it is not that case because oxymetazoline, xylometazoline, these drugs, they are alpha adrenergic drugs. When you think about alpha adrenergic action, it is gonna cause vasoconstriction. Okay. The decongestants are gonna do, they are going to create vasoconstriction. Peripheral vasoconstriction is what they are gonna do. Thereby decreasing, they will cause vasoconstriction and decreases what? Mucus secretion. Okay. So it is one of, it can be used as an adjunctive therapy for patients having nasal congestion. But the most important thing is that the maximum you can use these drugs is 3 to 5 days. Because they can cause something called rebound hypertension. Sorry, rebound congestion. Or rebound vasodilation, you can say. All right, they are problematic. They can cause rebound problems if they are used for more than 3 to 5 days, usually with shorter acting decongestants like oxymetazoline. Okay, so in that case, we have to slowly taper down and switch to nasal corticosteroid because, as I said, overuse can again cause permanent overgrowth of the nasal tissues. Nasal formulations are usually preferred in patients who cannot take oral formulations due to low systemic absorption or swallowing difficulties or those problems. Again, these can cause some nasal mucosa dryness, maybe tachycardia or bradycardia, hypertension or hypertension because it is all mixed, burning, stinging, sneezing, all these problems may occur. Okay, but most important thing you have to keep in mind is that they are causing vasoconstriction, the first thing. Second thing, if you are using it for more than 3 to 5 days, it can cause rebound congestion. It can cause rebound congestion. In when you talk about oral formulations basically what they do is that they can cause CNS stimulation. Then it can cause like insomnia or dizziness. It can cause or otherwise increase blood pressure it may cause. And in hypertensive patients, in hypertensive intensive patients only, it can cause increased blood pressure. Some glycemic changes in diabetes, and it can also cause peripheral vasoconstriction. It is a problem, right? So they have to be used within safely, and they should be avoided in patients with cardiovascular diseases, hyperthyroidism, because epinephrine, etc., is very problematic. Basically, they can cause they cannot be used in hypertension, diabetes, hyperthyroidism. It cannot be used with MAO inhibitors. Then Angle closure glaucoma. If you are planning to take these, MAO inhibitors should not be used within 2 weeks of taking this medication. So it's very, very important. Okay. Next one, we are going to discuss about immunotherapy and some other pharmacological options. We will continue in the next video.